You're listening to the Assembly on Sleep and Respiratory Neurobiology podcast, brought to you by the American Thoracic Society.
Hello, welcome to the Sleep Pioneers podcast. I am Perez, a member of the ATS Sleep, Respiratory, and Neurobiology Web Committee. It is my privilege to host our esteemed guest, Dr. John Remmers. Dr. Remmers is a physician and respiratory physiologist who retired 15 years ago from his academic position as professor at the University of Calgary. His research has focused on control of breathing and sleep-disordered breathing. He published the seminal paper in 1978 that led to the development of the field of sleep-disordered breathing. Welcome, Dr. Remmers.
Thank you, Iris. Nice to be with you.
To start, tell us more about your background and education.
Sure. I grew up in Louisville, Kentucky, so people might think I'm a Canadian where I live now, but I'm a USian in origin. I grew up in central US. I attended Dartmouth College and then Harvard Medical School. After the medical school at Harvard, I spent a year as an intern in internal medicine at Boston City Hospital, the Harvard service of Boston City Hospital. So that's my educational background that really felt very fortunate to attend just excellent undergraduate and medical school training and education. Medical education began at Dartmouth Medical School, which at the time was a 2-year medical school. And after spending 2 years there, I did a year of research with my mentor, Dr. Marsh Tenney. I was really the first of a number of trainees that came through Dartmouth and were mentored by Dr. Tenney in respiratory physiology. So it was a great privilege. He was an outstanding physiologist, but also himself was a physician and dean of the medical school at the time. So that was my first introduction to research and was very seminal. It was a year, and I learned about physiology, not just the aspects of the mechanics of breathing and gas exchange, but really also putting it all together in a synthesis that allows one to describe the whole organ system. And that was a great feature of working with Dr. Tenney. In addition, we spent a good deal of time thinking about hypoxia and life at high altitude and did research at high altitude. And this then, by chance, became very important later in my life when I started to deal with the potential consequences of hypoxia during sleep. My other mentor was a person that I met at Harvard Medical School. At Harvard at the time, one could have a number of electives, and I was interested in research and happened to know that I think the most famous and important respiratory control of breathing physiologist in certainly the second half of the 20th century was there. His name was John Pappenheimer. Dr. Pappenheimer is a very famous and established physiologist, but he happened to be working on central chemoreception and doing this in awake goats where the cerebral spinal fluid could be perfused and changed with regard to pH and bicarbonate. But this was an incredible opportunity for me, so I took all my elective time, put it all together in one lump, 6 months, and spent it in Dr. Pappenheimer's lab every day, sitting right next to Dr. Pappenheimer and the goats. An incredible experience. Those were my two mentors, one at Dartmouth and one at Harvard. And I must say I was absolutely blessed. Just a word about Dr. Pappenheimer. While Dr. Tenney emphasized hypoxia and control of breathing and synthesis of mechanisms into a total behavior, Dr. Pappenheimer was able to probe deeply the control of breathing by incredible preparations, the awake goat, and allowed development of really incredible insights. What I really learned, though, from Dr. Pappenheimer, most of all, was that if you're going to do research, you really should try to do something great. You should try to do something good. And he had done great work, and he was at the time doing great work. He inspired me to try to contribute something that was very special and important. So I sitting next to Dr. Pappenheimer, came away with this inspiration, really, not just a search for new knowledge, which I got from Dr. Tenney, and I got from Dr. Tenney also a very great interest in comparative physiology, but in addition, from Pappenheimer, it was you need to do something great. You don't want to just do research and make some minor contributions. You need to do something great. So that was quite an inspiring time for a 23-year-old kid. Those are my mentors and my background. My professional development was quite unusual. So let me just mention that a bit, Iris. I had competed for and won an esteemed internship at the Boston City Hospital at the time, and was working away when I got a letter from the President of the United States saying, we need you to join in this upcoming war. They were not yet drafting standard recruits, soldiers, but they were drafting physicians. So I was conscripted, decided that I would try to carry on my research career in the while in the being drafted, and I joined the Public Health Service and had hoped to spend time at the Harvard School of Public Health with the famous respiratory physiologist there. That didn't work out, and I was instead assigned to Los Angeles, where I worked in the General Hospital and studied the health effects of air pollution. So that was quite a change in my an interruption in my academic career progression. So after the 2 years, I'd really thought a lot and about what my goals were and what I was best able to do. And I made a fundamental decision not to return for my clinical residency at Harvard. So that was a huge decision, but it was one that was made based upon my desire to have a strong research career. And it colors everything in my life. After that, then I did postdoctoral work as a physiologist back at Dartmouth and began to work on control of breathing and ultimately control of breathing during sleep, but basic aspects of control of breathing, the neural cellular behavior of respiratory networks in the generation of breathing.
So how did you get interested, or from your background, to get involved in sleep medicine?
I was simply, at this point, a respiratory physiologist. Obviously, I was a physician and I'd had some training in internal medicine, but I was just a respiratory physiologist. My hope was to find something that would be important about control of breathing. And as you know very well, there's not much that goes wrong with the control of breathing in normal awake people. So unlike control of blood pressure, where normal people seem to get hypertension and it has all kinds of ill effects on the body, there wasn't something comparable. You don't see people who are otherwise normal who just start to hypoventilate while awake, unless you have some trauma or some drug problem. The control of breathing is more or less perfect while awake. So I was looking for something that might use my talents, where I might be able to contribute something, and developing models of breathing, we developed awake cat models and could monitor their ventilation accurately while awake, sitting in a box, and measure their carbon dioxide and so on. So I said, well, we ought to just look at what happens when the cat goes to sleep, and studied the changes in breathing that were caused by sleep. Nothing special. The timing changed, and we could understand why that happened, but there wasn't much special that happened there. So that wasn't how I actually got into sleep medicine. This was just studying sleep, though. So I thought, well, maybe there's something that goes wrong in human beings during sleep. And I had no reason to believe that. I was very interested in the role of the larynx in controlling breathing and how it behaves with inspiration and expiration, and studied that, but in the animal models. But it just dawned on me that maybe there is something that goes wrong with breathing during sleep in human beings. I had no idea. About this time, I moved. I moved from Dartmouth to the University of Texas Medical School in Galveston, and that occasioned a change in my type of research. At University of Texas, they wanted me not only to have a respiratory physiology lab, and I supported research there, but they also wanted me to have some kind of clinical research going on. So it was occasioned by my change in institution. I had wonderful people that I was associated with there, but they were willing to support me in a way that allowed me to have 4 kids, a substantial family, so long as, but they wanted me to do some clinical research. And usually that meant pulmonary gas exchange, pulmonary mechanics, and disease, and so on. But that all been pretty well worked out, actually. And the high points, halcyon days of pulmonary mechanics and pulmonary gas exchange were really pretty much past. And so I thought, well, I don't know what I can do clinical research on, but why don't we just see what happens to people when they go to sleep? What happens to their breathing? So now I was set up to do some sleep respiratory studies. I set up what it would be called a sleep lab. It wasn't there. It's the first oximeter, the Hewlett-Packard oximeter, which is this big turbine-like thing that went on the ear. I measured pressures in the esophagus and flows through a mask, and it was all pretty wild, and all this occurred in a closet, and that was my sleep lab. So I was going to see if there's anything that went wrong with breathing during sleep. And sure enough, one day I was asked to have a look at a patient. His name was Robert Fulton, and he wouldn't mind my saying his name. This was now 60 years ago, almost 50 years ago. This is almost 50 years ago. So this gentleman he was a black man, middle-aged, with a protruding abdomen, and I was asked to see him because he had a high arterial CO2 pressure, high PCO2, without lung disease. So that anybody that knows anything about breathing knows that if you don't have lung disease and your PCO2 is high, whoa, that says there might be something wrong with your control of breathing. And so I said, wow, Robert, what are you here for? And he said, oh, I've got this broken leg. And I said, oh, I'm sorry. How did you break your leg? He said, I fell off the back of a truck, a pickup. And I said, oh, were you up there and lost your balance and fell off? No. I was standing on the back of the pickup, and it was riding down the road, and I fell asleep, and I fell off the truck and broke my leg. You broke your leg because you fell asleep on this moving pickup? Yeah, that's what happened to me. I said, well, Robert, maybe I need to study you. We have CO2 retention through the day, and a sleepy man, maybe this would be interesting. It's already known that people could have Pickwickian syndrome and be obese, have cardiorespiratory failure, PCO2, and it was thought at the time that the major pathophysiology was obesity, was the mass load put on the respiratory system and the respiratory muscles by this enormous morbid obesity. That was what was thought. Nobody had ever walked into the patient's room at night, though, to see what was going on. So that was in the background, that there were fat people who had sleep apnea, who had cardiorespiratory failure and died. And so here was Robert Fulton, and I studied him at night. Well, I got Robert all set up, Iris, with 2 pressure transducers down his throat, and EEGs going, and oximetry. It's a very new thing, but I had oximetry going. And I said, good night, Mr. Fulton. Have a good rest. And I walked into the next room where a polysomnograph was going, and I just saw the oxygen. The oxygen was plummeting. I was astounded and shocked and worried. So I ran back in the room. Said, Robert, are you all right? Wake up. I said, yeah, I'm all right. And so I said, okay, well, I just worried about you. And went back in the other room and looked again at the polysomnogram. Oxygen was plummeting down to drastic levels. So I didn't know what was happening. I did this a few times. And I finally realized that Robert was having obstructive sleep apnea. Could see the efforts being made, and I could see that he wasn't breathing, and but it was astounding and scary. So I watched him through the night, and that was my first encounter with obstructive sleep apnea. I then went on to just to explore the mechanisms of that. And it really meant doing what I do as a respiratory physiologist, measuring airflow, measuring pressures in the pharynx, pressures in the esophagus, and so on. So I described what I thought was kind of a new disease, and I thought, well, this is very cool. Here are people who have, and maybe some of these people are Pickwickian syndrome people. Well, that was fine until I would present this at the University of Calgary, and present this to my colleagues at University of Texas in Galveston, and they said, well, that's nice, but you ought to go see Ebo. I was a young guy, Aris, and I'd just discovered a new disease. I felt pretty proud of myself, clapping myself on the back and so on, and I didn't need to see anybody. No, you got to go meet Ebo. And so finally, despite my arrogance and pride, I did one day meet Eberhard K. Sauerland, and he lived in the basement of the next building over in the Department of Anatomy. And why would I want to meet Ebo? And I talked to Ebo a little bit and realized that Ebo was a German physician, want-to-be neurophysiologist who had started at the dental school at UCLA, and there was sent over to and in the dental school, he had taken on the study of the genioglossus muscle and its behavior during swallowing, because it was thought that the misbehavior of the genioglossus on swallowing led to protrusion of the teeth and misalignment of the teeth. Well, he was studying that, but what did he discover? He's smart guy. He discovered that there was this respiratory modulation of the genioglossus in awake people. That's the end of the story that he had. He discovered that. He didn't publish it, maybe in a small private journal, but he had not done anything in the way of letting people know about this. And then he moved to Galveston and happened to be, of all the places, right next to where I was at the same time that I had come up with this pharyngeal obstruction in obstructive sleep apnea. And so it was just obvious that the two of us need to work together. I mean, it was incredible. He knew all about the anatomy and now the respiratory function of pharyngeal muscles. I knew how to record the EMGs just like he did. And so we went off on our way together recording the EMGs of the genioglossus muscle in obstructive sleep apnea. So there it happened. That's the way it all happened for me, Iris. I'm telling you a long story, but it all happened because I got interested in sleep. I wanted to find out whether people breathe normally during sleep or whether there was possibly some problem. And I saw this huge problem in some people, giant problem, and happened to have a collaborator in the same institution who led me to together. We were able to define not only the collapse of the pharynx and the pressures and flows related to that, but also begin to look at the neural factors, because we could record from the respiratory muscle of the pharynx, newly discovered, this muscle that dilates and stiffens the pharynx in all of us all the time, but is particularly involved in obstructive sleep apnea.
So, of which achievements are you most proud?
Well, that the most important thing that I did as it turned out. You don't know what's going to be important when you're just a scientist working away, and so it turned out that 1978 paper that was published with Sauerland was a seminal, what would normally be called a seminal paper, started a new field, basically, and that contribution would be the one that I'm most proud of. I would say that. It clearly, subsequent papers and contributions I like very much, but in terms of being proud, I guess I don't know that I'm too proud of any of it. That's a little bit of a tough one for me. I would judge it's probably the most significant contribution. Could we put it that way? I'm really not a proud sort of fellow. A little bit of a story, and I give you another place though that I think I was part of an important contribution. At the time that this contribution was made, there was no plan at all for there being a large part of the population that had sleep apnea. As a matter of fact, I was hoping that maybe it'd be very defined, just in really obese people, or something like that. And that I was just a physiologist and physician. That's all I wanted to do. Okay. And then along comes Terry Young showing that 10% of adult males have this disease, and staggering. And then a little bit after that, it's 15%. And, so it becomes clear and awful and striking that we have a lot of people with problem breathing during sleep that's called obstructive sleep apnea. Wow, I didn't want that at all. I had no interest in public health research, really. I was a physician. I cared about people and public health, but this was not my life. I'm not an epidemiologist. So it was tough. But I learned clinical epidemiology, and I have tried then to deal with the public health problem. And that the contribution is a little more nebulous, but I'd like to refer to it. Excuse me a minute. This occurred at the University of Calgary, and in Calgary we had a sleep lab. This was now more like 30 years ago, and CPAP had been discovered, and we were happily treating people, doing polysomnograms and starting them on CPAP. There was, however, a problem, and that is we had a 2-year waiting list. We had 5 beds going. I had colleagues involved with me, but no way we were going to keep up with this horrible problem. No way. And so we had a chat and said, we really need to deal with this in a creative way. And that caught my attention. And so we, Dr. Bill Whitelaw and Dr. Ward Flemons and I, set about to, number one, develop technology that would allow us to deal with this huge demand on our services and perhaps start to deal with the public health problem of sleep that we were aware sleep apnea was. That led, I'd already been involved in the development of CPAP, and I think probably invented the first auto CPAP with a gentleman named Tom Farrow here in Galveston. So we had here in Calgary, and we had then the ability to initiate therapy without an overnight study in the sleep lab. So that was there, but we didn't have any way to diagnose sleep apnea really. And we set about then to develop a home diagnostic system or some type of monitor, and did that and came up with what I think was the first valid or validated home sleep test, simply based heavily on oximetry. And in any case, we set about then to deploy the diagnostic device and the therapeutic device into the home without ever carrying out a study in the sleep lab. And this, we thought, we partnered with a private enterprise here in Calgary. A number of companies were interested in carrying out this home diagnosis and initiation of therapy in the home with an auto CPAP. And turned out it worked beautifully. So here we are then, still have 5 sleep labs, but the waiting time goes from 2 years down to a few months. Still too long, but okay. But all the garden variety of sleep apnea in Calgary and soon in all of Alberta was diagnosed and treated in the home. And I think we call that the Calgary model. I was just a part of that. I was the inventor of some of it. But I had these incredible colleagues who were not turf oriented for some reason. They didn't say, we want more sleep labs, which they weren't going to get from the government. We want to make more money doing sleep tests and so on. It is, here's a solution that we think will get the job done and do it efficiently and inexpensively. And so I was a part of that. And I guess I feel a lot of kinship to that achievement. And I don't say it's the first, but it was one of the first sites in actual practice where a city of 1 million was getting the sleep apnea diagnosed and treated in the home, and I think stood out as a way that an alternative to the traditional and endorsed polysomnogram CPAP model.
So what brings you the most joy professionally?
Yeah, my colleagues. That is a source of real joy. I mean, I'm going to leave aside science. I mean, clearly science and solving scientific problems, making breakthroughs, enhancing understanding, that's joyful, but in a different sense. That's satisfying, let's call it. But you're getting at something that's joy and relates to human beings. And so my colleagues, whether they're the students, graduate students, postdoctoral fellows, or just this vast array of friends that I have, really gives me lots of joy. And to this day, I'm an old man, and I've got all these friends that I correspond with regularly, call regularly, and still collaborate with. And so I those are the people that give me great joy. And these are people that made enormous contributions. I was joined in Galveston by Magdi Yunus. He's brilliant and made enormous contributions subsequently after he left me in sleep. I'm very close to Naresh Punjabi as a young man, and still am, and to Dr. Ward Flemons, who heads up the pulmonary division here. These are people whom I treasure. I have to say that's a source of great joy. The other, of course, and I don't have to tell you this as a physician, is the patients. I mean, I was an incompletely trained physician specialist, but I could go to clinic and see people with sleep apnea, and did that. And it was hugely fun and rewarding. And I feel to this day, I remember the patients, the very individual patients, and I remember their response to the very first CPAP that I had invented, and we tried out on patients, and this type of thing. So I do enjoy very much I did enjoy very much the interaction with patients.
And what brings you the most joy personally?
My kids. So, yeah, part of deciding not to be a busy clinician was to have time for my family. So, no doubt, being a dad, devoted dad, always there dad, has been a great joy for me, and is to this day. Very much. And I'm fortunate they're all healthy and have their own families. And I feel very, very fortunate about having these 4 children.
How did you keep up your career momentum?
Wow, my career momentum. It has a life of its own. I have I don't try to keep it up. I'm devoted to a few things in life, as I was when I was academically active and active in research. I was also a heavy duty runner, ran marathons, and so I had a full life. But there's just no stopping it. I'm devoted to discovering new knowledge. It is for me a great achievement, and if we can contribute by providing new insights, well, I'm all over that. So I guess I did very little to maintain momentum. It maintained itself because I so adored life as a scientist. I've changed my life now. I have a second career. I retired, as you mentioned, 15 years ago from an academic career and from an actual structured research grant supported activity as a scientist. I rather than try to influence the world through business and through actual application of scientific insights to people and to healthcare. So I've had 2 small businesses that I was involved with, and they were both great fun, not successful financially. And so that just says a lot about the technology, which was very good technology, but not suitable for the world, and about my abilities as a business person. I'm now associated with a company that I didn't start, but provides the world's best oral appliances for treating sleep apnea. So I'm involved in a company that studies the alternative to CPAP and provides an enormously productive and good mechanism for doing that. We're in the throes of developing an intraoral oximeter. I call it a buccal mucosal oximeter that sits on the upper appliance, and shown that it gives very accurate results in awake individuals. So we're still working on this type of thing, but it's a bit different. I'm trying to change the world, not through scientific discoveries, but through my influence and support of people who are developing therapies. I'd like to say perhaps the most important, talking about technical innovations. I'm very happy with our current technical innovation of buccal mucosal oximetry, and it's really very new, never been done, and I think has the potential of changing the patterns of practice around sleep apnea. But we should not overlook the most fundamental achievement in the field of therapy of sleep apnea, and that's the discovery of CPAP by Colin Sullivan. That happened about 4 years after my paper describing the mechanisms and pathophysiology of obstructive sleep apnea. Colin's contribution, it is enormous. He deserves a Nobel Prize for it, but they don't give Nobel Prizes for this type of contribution. But he's the millions and millions and millions of lives that he's influenced, both from a health point of view and a quality of life point of view, just cannot be overestimated. So I want to just say that I that followed along and invented better mousetraps and improvements or contributions to CPAP. A lot of us have done that. But the man who discovered, he discovered the nasal airway in the process. And the nasal airway is now used for, as you know, a lot of other things, non-invasive ventilations. So I give Colin Sullivan enormous credit and think that he deserves the real accolades of our field, because it's been such an enormous contribution. I think we need to have other therapies, but do not mistake the importance of the contribution he made.
So in your career, is there anything you would have done differently?
Oh, that's a tough question. Sure. As I described, I was at this pivotal juncture where I could carry on with my clinical training in internal medicine, or I could leave it and move into training in basic respiratory physiology. I'm happy with the decision I made. Lots of people who know me were not happy with it, but I'm happy with what I made. But certainly I could conceive of doing it differently. My life would have been very different. I think I would be an academic pulmonologist and have a totally different impact on the world. I'm not sure that any of this sleep would have happened. I'm not sure. But I think it was a juncture, and overall, I'm happy with the decision and how it turned out, but could have done it very differently there.
So, if you had not been involved in sleep medicine, what do you think you would have done instead?
Well, just leaving aside medicine, I really, there's no doubt that I'm an inventor or developer of ideas and things. And so I think it would have been quite different. It would have been something in the area of art, painting, perhaps architecture. It's been a great appeal for me. So either one of those, painter or architect, and this changes, as that would have been the case in my 40s and 50s and 60s. As an old guy now, I have very different interests. I've always had an interest in physics, so for me, I look forward to physics. I plan to. So I could have had another career as a physicist. I think the mathematics is very tough, but maybe I could have done it. But nowadays, when I step down from my current job, I plan to, looks like I'm going to study gravitational waves, and astrophysics. These are the things that are so incredible to me today, and I'll reflect on the Earth and how we exist in the universe. So I guess that's where I would like to spend the next few years when I retire.
What has surprised you the most over the course of your career?
The surprise for me, I guess, that it was one, that I could do something that had an influence, end up making a seminal contribution. I never thought I could do that. And that we could actually change how people's lives were influenced through diagnosis and treatment of sleep apnea. That's an amazing surprise. I arrived here 40 years ago in Calgary, Canada, and the gentleman who was hiring me, head of a foundation, it was saying, "Oh, you will make these great discoveries that will impact the health of all Albertans." And I just rolled my eyes. I mean, man, what are you smoking? I mean, but this is what's going on here. I don't contribute anything that's going to help people's lives. Well, I was surprised. In fact, I and my colleagues, we put our shoulders to the wheel and we worked on things, and it turned out that we were able to have an impact. Well, that's very surprising for me. And I just wanted to mention that's the surprise of the week. First of all, the first surprise is the magnitude of the public health problem related to sleep apnea. I had no idea, and I was hoping against that. But it's amazed at the size of the problem, and I am surprised that we've made so little progress in dealing with it. So I'm going to give you my disappointments also. They're surprised. I was surprised. Surprised that more has not been done to deal with the public health problem. I think we're very good as physicians in dealing with individual patients who walk in the clinic door. I think we're less good at dealing with all the people that couldn't walk in the door. So more access and then better treatments. And I guess that surprises me, and I had not envisioned that. I grew up in the era of the lung associations. Before the American Thoracic Society, there was the Lung Association. So I was a member of the Lung Association. And what did we care about the most? We cared about the neonatal situation in your field. But the dominant thing we cared about were people with emphysema and bronchitis, it was called. And they were smokers. And what did we do? Well, we didn't just investigate them or take care of them when they crashed and went to the hospital. No, we also engaged in anti-smoking campaigns. So I wrote many a letter and partnered with several other anti-smoking individuals and organizations. And it was great fun, but we had a cause. We were trying to deal with the major problem. TB was gone. So initially it was tuberculosis. And now in my era, when I was a young man, it was smoking. And I think we had an impact. We worked on that and talked about it and lobbied Congress and so on. Well, I don't see enough of that right now. That's all I'm saying to you, is that I don't see enough of it. We had a great leader in Bill Dement 20 years ago who led the effort to influence Congress and influence the NIH and so on. But I want more concern about the million of people, so total 1 billion worldwide, that have sleep apnea and whose life is compromised, quality of life is compromised, or their cardiovascular health is being impaired. I don't think we think about it enough. And we don't think then enough about obesity. And we're driven by patient care, but often with their convoluted vested interests that lead us not to be aggressive about the public health problem.
Thinking about the future, what do you think are the biggest challenges for the field?
It's bringing convenient, efficacious treatment to the multitudes of people. Okay, and I'm just comparing sleep apnea, sleep disordered breathing, to diabetes and hypertension. Okay, these are the two comparisons that are made. And the number of undiagnosed patients, percentage of patients that are undiagnosed, is much larger. And it's a problem with that. So diagnosis and then acceptable, cost-effective, convenient treatment. So it's a health epidemic in my view. So for me, the big steps in the field in the future is maybe we'll have some pharmacological success. I think right now, just a simple oral appliance is the most important way to go. But I think we may have a pharmacological success, and then combining that with convenient diagnosis and then management. We have to be able to monitor our patients. That we have something equivalent to the little patch that's worn on the arm by diabetics and monitors the blood glucose. We need to do the same with monitoring oxygen during sleep. The corresponding variable to the blood pressure for hypertension and glucose for diabetes is arterial oxyhemoglobin saturation. We need to monitor that and manage the cardiovascular risks and possibility of catastrophic cardiovascular events.
Before we end, what advice would you give people who are new to the field?
First of all, I would try to attract them in because I think we need new people. And our field is not growing. So this is another problem that we face. It's not growing because we don't have enough excitement in it. So I would attract in people through excitement, whether it's in your area, neonatology, pediatrics, or whether it's in adults. I'd urge them to not only deal with, if they have an inclination towards clinical epidemiology, to dealing with clinical trials and the public health problem, but also the enormous possibilities that we have in areas like gestational OSA, like dementia, and the reduction in cerebral blood flow caused by OSA, like PTSD, the veteran whose life is ruined and has sleep apnea but cannot wear CPAP. These are areas that, so I would urge the new person in the field to seize in one of these areas that looks like we have sleep apnea that we haven't been able to deal with well. I mean, I don't think we've dealt with any of those three well yet, and make a real contribution to one of those three areas, for instance. That's where I'm still trying to work in those areas. Those are areas that I think are ripe for real clinical research and advancement. I hope that helps. I would urge the new person in the field to be open. This has not been a field that it's been a young field. It's the societies that relate to it have been focused on getting it established as a field that is recognized, and that's all extremely important, extremely good. I'm totally supportive of that. But I think it's time now to move beyond polysomnograms and CPAP and look toward the advances beyond that. I've given you an example of three, but many more. So my advice fundamentally would be open-mindedness, a lack of vested interest, and really the engage in the excitement of the adventure of changing how care is delivered in the 21st century for this enormous public health problem.
Thank you, Dr. Remmers. It has been a pleasure to speak with you today.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.